So in terms of, so that's a great question. In terms of looking at patients for selection for osimertinib, the key question is whether their tumor harbors the EGFR T790M mutation as a mechanism of resistance to their previous EGFR TKI. So in terms of testing for that, we can look at your general tumor biopsy and look for T790M, or you can look at plasma cell-free DNA, tumor DNA that's shed in the blood and can be picked up and sequenced. In general, I incorporate both plasma cell-free DNA and tumor EGFR T790M testing into my clinical practice. So in terms of sequencing therapy for patients with EGFR mutant lung cancer, I generally look at the first-line approved EGFR TKIs, where there's erlotinib, gefitinib, and afatinib. So I have a discussion with the patient regarding the pros and cons of each one. For example, if they're older patients who are frail and have more comorbidities, I like the side effect profile of gefitinib, so I discuss gefitinib with them. If they are robust and young, and they have an EGFR exon 19 deletion based on the results of Lung 3 and 6 showing a survival benefit compared with chemo in those studies, I discuss afatinib or erlotinib. So we have a discussion based around the patient to individualize which first-line EGFR TKI we think is right for them. And based on that, put them on either afatinib, erlotinib, or gefitinib. At the time of progression, hopefully they derive some benefit for some time, but when the cancer starts progressing again, I look for the presence of EGFR T790M either in tissue or plasma, and if it's positive and they're progressing with the tempo of disease picking up or high bulk of disease, or they're more symptomatic, I generally in those patients switch to osimertinib. I also, if they're T790M negative, and I've really looked carefully both at plasma and tissue and it's clearly negative, I look for other treatment options such as your standard platinum-based chemotherapy or clinical trials. We have several clinical trials specifically focusing on T790M negative patients at UC Davis, so we often discuss those as well. In terms of the NCCN guidelines, my practice generally follows the guidelines. They divide them into asymptomatic versus symptomatic, and so if the patient's clearly symptomatic, that's an indication for change. I don't like to wait to get to that point where patients are having substantial symptoms before switching therapy, so that's where I go back, and even if they're asymptomatic or minimally symptomatic, look at the bulk of disease, the tempo of disease, and those can also inform, I think for many clinicians inform clinical decision making. If patients have one lesion that's growing in particular, excuse me, if one lesion's growing in particular, they have what we call oligometastatic disease, I will often look to radiate that focus of disease and then continue the same EGFR TKI they've been on. And there's data for that showing that you could get some extra mileage and extra kind of additional, quote, progression-free survival based upon that strategy of radiating the one site of disease and continuing the TKI that they've been on. If they have several lesions, now that especially if they're T790M positive, I've moved more towards osimertinib, but if there's one lesion, for example, that's isolated and easy to take care of through focal radiation and so forth, that's something that I also look at time to time. And I think that's also consistent with the NCCN guidelines. Another thing to keep in mind, if I do think they're progressing, I often will check a repeat brain MRI, because sometimes at the time of progression you also not infrequently pick up new brain metastases that also may change, bring in potential radiation or change in treatment sooner rather than later. So that's another thing that I look at as well, where there's also data for radiating, for example, SRS to a oligometastatic brain lesion and continuing the TKI that they've been on previously. So those are my general approaches to treating EGFR mutant lung cancer and sequencing treatment, although they're individualized based on the patient.